delivered two fine, strapping boys of hers here on the front row. So thanks a lot for thinking about me and coming tonight. I'm going to tell you some things tonight that I have never shared really with anyone. Some things that are very personal. I had a wonderful, wonderful practice, and it continues to be something that I enjoy reflecting on. I'm going to start out by giving you a little introduction, and then I wanted to talk a little bit about practice management and how we operated with that. And then I want to take you into the encounters of a few of my patients and the problems that they had. And finally, I'm going to wind up with history of medicine during the latter half of the 20th century, which is the time that I practiced. I was born in 1936 and reared in Rutherford County in the Dilton community on Lytle Creek. I entered first grade at Critchlow School with Miss Jeannie Nilsson as my teacher. Subsequently, I attended Central High School here and graduated in 1955. Then I entered Vanderbilt and graduated in 1959 with Pat Kilo, and had a wonderful experience there. Finally, I attended the University of Tennessee College of Medicine in Memphis and graduated in 1963. Postgraduate studies included an internship at Methodist Hospital in Memphis and a residency in psychiatry at UT for 1 year. I returned to Murfreesboro in 1966 and entered the private practice of family medicine, partnering with Dr. Paul Estes in a little old house on North Highland Street, just behind Rutherford Hospital. After some 6 years, I moved into a solo practice at 421 East Bell Street on the grounds of the old Eaton College. My waiting room was large and spacious and furnished with very comfortable chairs and sofas. This was so that my patients could select a sitting area away from contagious disease if such was suspected. I had a rather elaborate office. Some of you visited my office. Had very nice furnishings, and I was criticized somewhat. Why do you have all this nice furniture in here? Don't you know the patient's going to tear this up? That didn't happen at all. My patients really appreciated the comfort of those nice furnishings, and I still have some of them in my home today that were maintained just as well as they would have been in any situation. My patients really appreciated the facility that we had designed for their comfort. My practice was very gratifying from the outset. Mary McClary Ralston, an RN and a well-respected individual in the community, was my first nurse. I had 3 nurses in my entire practice of 40 plus years. 3 nurses. Some of my physician colleagues had 3 nurses a year. I mean, I tried to be considerate and appreciative for my nurses, and they were so dedicated to me. My office hours were from 10 a.m. until we finished, and that might be 6 or 7 p.m. I would usually have 6 to 8 patients in the hospital, but eventually this increased to 15 to 20 patients. I became the largest admitter to Rutherford Hospital, Middle Tennessee Medical Center, for over 20 years. The hospital charge nurse would make rounds with you and write orders. That never happens anymore. You had the advantage of the charge nurse making rounds, telling you the aspects of the patient's course in the hospital, and just filling you in on a lot of matters that you needed to know. And unfortunately, that has totally changed. I was usually on call every other night and every other weekend. We worked by appointments, but as you know, we could seldom keep them because we had the delivery room calling, the ER calling, the nursing home calling, and so forth. We also would make house calls on occasions, but gradually we tried to reduce these to almost none due to improvement in treatment methods. I never, ever refused to see a patient because he couldn't pay me. I charged $75 for delivery. I don't know what the cost today.
A little more. It's gone up just a little.
My maximum was $125. My office visits, they were pretty outrageous too, $12 to $15, depending on what you had to have. To what do I credit my good patient following? I believe strongly in giving them a listening ear. I would often tell the patient, you know, I can sit here with you for 20 minutes and have you tell me about your problems, or I can write you a prescription and get rid of you in 5 minutes. So I chose the former rather than the latter in most cases. I had been taught to obtain a good history from the patient and then follow this with a complete physical exam. The computer never entered my examining room because we didn't have computers. Thank goodness. My nurse was always to accompany me for my physical exams. I never wanted to do that without the accompaniment of my nurse. I always wanted to know what was happening to my patient. For example, the patient would tell me they're going in the hospital for surgery next week. I want you to come by and see me, doctor. And I would go see the patient, and I would follow that patient. I wanted to know what was happening. If the patient needed to be referred to a specialist, I was there. I wanted to be sure that I sent them to the best specialist. There were some I didn't want them to see, and I saw to it that they didn't see them. So I wanted to be involved. And I made sure he was excuse me, referred to the best. Now a word or two about practice management. What do we mean by that? My wife, Barbara, became an integral part of my practice, serving as my practice manager. Medicare was signed into law by President Lyndon Johnson on July the 30th, 1965. And you know where? In Independence, Missouri.
Yep.
And you know the first person to have the first Medicare card? President Harry Truman. I thought that was an interesting fact I shared with you. Medicine would be changed forever with the intrusion of government and its regulations which would follow. First came CPT, that's current procedural terminology codes. Then these designations would be followed with ICD-9 codes, International Classification of Disease, which would have to be utilized to qualify your charges to Medicare. You couldn't just send a charge in. You had to use these codes. And needless to say, my practice manager was my major advocate for success. Barbara came to know these codes and their designations expertly. She was invaluable and made my practice the gratifying experience that it became. Barbara became one of the most knowledgeable individuals of the insurance industry in Middle Tennessee. She knew these codes up one side and down the other, and that was an absolute necessity. Now I want to talk to you a little bit about some specific patient encounters. One of the first ones was a lady that many of you may know, Maggie Vaughn. Maggie was one of my patients. She was poet laureate of Tennessee. She was a real trip. Still is. Hilarious and always pleasant, funny, laughing. She lived in Bell Buckle and had minimal income. And she would barter with me. One of my few patients that would barter, offering me some of her art pieces or some of her books or other things. But she was a delight to care for and very appreciative. Another patient was Miss Willie Scales. Miss Willie was the mother of T90 Scales and the grandmother of our city councilman, Madeline Scales Harris. Dr. Coopwood was the first African American to acquire privileges to participate in the care of his patients at Rutherford Hospital. And he came to Murfreesboro, and I told Miss Willie on one of the occasions when she was in my office, I said, Dr. Coopwood is here now, and if you would like to, I want you to know that I will not be offended if you go to Dr. Coopwood as your doctor. And she sat there a few minutes. She said, oh no, I want to keep my white doctor. So she did, and I took care of her for several years after that incident. Dr. Tom Johns, an orthopedist, was my patient. It was always gratifying to have one of your physician colleagues to have confidence in your medical competency and to seek out your care. The question comes, how many patients did you fire from this practice over 40 years? Only one patient that I fired in 40 years. She was a female MTSU professor, very inquisitive, abrasive, aggressive, and impudent. And I said, I don't have to fool with this. You get you another doctor. And that was it. The only one I ever dismissed.
Can you tell us what department?
Doesn't have to remain nameless. What was the worst experience in all the years of my practice? The worst experience, a horrible experience I'm going to share it with you. As I told you earlier, it occurred in the delivery room. The patient had had an uneventful prenatal care for a 33 or 34-year-old woman in her second pregnancy. She came to the delivery room in early labor and had no unusual events during her course of labor. Finally, the delivery ensued, and the baby was delivered with ease as a live birth. Immediately after delivery of the placenta, the anesthetist said, "Doctor, I have lost the patient's pulse." And immediately the patient went into cardiac arrest. Emergency measures were undertaken to no avail. She had sustained an acute air embolus. Always a fatal outcome in spite of all the heroic measures. You wonder why this doesn't happen more than it does. Thank God it doesn't happen very often. But when the placenta separates from the uterus and the uterus begins to contract, an air bubble can enter the circulation and go to the heart immediately, and I mean, it's death note. Having to face a husband with this outcome was certainly devastating for me. If you deliver enough babies, unfortunately, you will experience such a catastrophe at some point. Also, you have the pregnancy resulting in a stillborn delivery. This is a major encounter as well with the patient. But aside from these, I had very gratifying experiences with the delivery of upward of 2,000 to 2,500 babies. I had one encounter, as a side note, with a little Roma, R-O-M-A. You know what a Roma is?
Pizza.
Gypsy. I had one encounter with a little gypsy lady who presented at the ER in full-blown labor. She had had no prenatal care. I took her to the delivery room and had an uneventful delivery of a normal live birth. On the rounds the next morning, she wanted to be discharged. Well, back then, we usually kept patients in the hospital 2 or 3 days. We don't do that anymore, thank goodness. But I told her to have her husband to come to my office and settle her bill. An hour or so afterwards, the nurse called the office and said they were tearing up Jack, demanding to be discharged. Needless to say, they left the hospital never paying the bill. That was my only experience with the Roma. I wanted to tell you about patients. I had 4 patients in my practice over the years with tetanus. And that's very rare, thank goodness, but it's a terribly critical disease. Patient comes in, can't swallow, drawing in the neck, and then it's called trismus. And these were 4 elderly men who had never had tetanus immunization. And 2 of them made it through the course of that illness, and 2 of them did not survive. It concerns me a great deal now. I think we're probably going to see more tetanus again, because we have some people who are saying they don't want their children to have DPT immunizations, and because of autism. And that's a fallacy. It has nothing to do with it. And unfortunately, if we don't give children their immunizations, they're going to be susceptible down the road for these infections. I want to tell you a little bit about an AIDS patient. This was a middle-aged gentleman with a history of general decline, with weight loss, lethargy, weakness, etc. He had had a history of peptic ulcer disease with GI bleeding over a 2 to 3 year interval. And he had required, in that course of time, multiple blood transfusions. He had to be hospitalized, of course, for evaluation of his declining condition. It actually didn't occur to me at the time I admitted him to the hospital what was going on. But here again, we had the head nurse, who was an astute individual, and she had looked at his chart and had studied his history. And she pulled me to the side one morning and she said, "You know, Dr. Tolbert, I believe this patient may have AIDS." And I had not even thought about him having AIDS. He was a married gentleman, worked at State Farm, had a very good job, and our studies actually confirmed within a few days, yes, he did have AIDS. So this was exactly proven to be the case. His ultimate demise, however, did not occur for another year or so. There, of course, was no treatment at that time for AIDS. He got AIDS through the blood transfusion. We have much better ways now of testing our blood, and AIDS is not a problem with blood transfusions anymore. I'll have a little more to say about AIDS down the road here. I want to tell you this about simultaneous deaths that I had. Ben Brown was a groceryman out at Las Casas. He presented to the office one day with chest pain, and it was suspicious, and I hospitalized him. He evolved with an acute myocardial infarction, an actual heart attack, over the period of a couple of days. His wife came in, Peggy, and she was fairly acutely ill with sort of a flu-like syndrome, and I thought with her being elderly that we should admit her to the hospital. A day or so later, Ben's condition took a turn downward and he died unexpectedly. I then had to go upstairs and approach his wife with the death of her husband. And when I did, she became very, very emotionally upset, thrashing about in the bed, and she herself proceeded to die right there on target. So that's what I call simultaneous deaths, right one on top of the other. I never had that happen again. That was the only time that ever happened. I wanted to share with you a couple of psychiatric encounters that are interesting. I had a severely disturbed patient in the hospital who was delusional and exhibiting some very bizarre behavior characterized by tissue mutilation caused by cigarette burns to his legs. He was taking a cigarette and just burning his legs, holes in his legs, crazy. The nurse called me at the office, and I subsequently went over to the hospital and saw the patient. And it was certainly appropriate when I countered with him by saying, if you continue to do this type of mutilation, people will think you are crazy. I shouldn't have said that. He immediately plunged forward and struck me severely on the face. Really scared me. I rushed to the nurse's station, signed emergency commitment papers for admission to Central State Hospital, and called the sheriff's office and told them to get out there immediately and take this man for immediate transfer, which they did. I was concerned, of course, we weren't equipped in Rutherford Hospital to keep mentally disturbed patients to that degree because it's dangerous, and I didn't want him to hurt one of the nurses or aides or something. Another one was a lady who had chronic schizophrenia and did well when she took her medication, but as so often the case, she would refuse the medication. She was a very devout member of the Church of God. And I had 2 Church of God women preachers in my medical practice. Unusual. One was Sister Jewel Jernigan. I don't know whether any of you knew Sister Jewel or not. The other one was a sister to Joe Lovell, city manager of the Mercersburg Water Department. Both of these were fine ladies. Sister Jewel was so helpful when I would call her to help intervene in this little lady's care. It was so good when you could utilize key individuals in the community to act as an adjunct to your care. Sister Jewel would tell her, now you have to take your medicine, you need to take it, and you need to comply with the doctor's orders, and the lady would settle down and do just what Preacher Jewel would tell her to do. And that was a wonderful experience. I want to offer you this pearl. There are 2 patients who can hurt you. One is a very paranoid individual like that gentleman, and the other one is a severely withdrawn, depressed patient. Always avoid confrontation with them if possible. They can hurt you. I had two severely burned patients, a husband and wife, who had used gasoline to clean a kitchen floor. And the pilot light on the water heater ignited a fire which resulted in third-degree burns to 90% of their bodies. When they arrived in the ER, both of them knew that death was imminent, but they were alert and fully conscious. They told me that there was a family couple in their church that they wanted to have rear their two children. Isn't that amazing? Mm-hmm. Right there in the emergency room. I wrote the names of the couple, the name of the couple, and following the death of the burned couple, the other couple presented in my office to verify the wishes of this severely burned couple. And I verified that, yes, you're the ones they wanted to have the children. And that was a unique experience and a very horrible experience. Lastly, I want to share with you the multitude of patients that gave gifts to me, particularly the food. I think sometimes they had something against me. Cakes, pies, ham, biscuits, candies, etc. One lady always gave me divinity candy at Christmas. And another still gives me, even to this very day, a jam cake at Christmas. Every year I get a jam cake from this patient. Perhaps the most notable gift was that of an antique Rutherford County cherry Jackson press. I had attended this lady on occasions in her home on house calls, and on one occasion I commented that the press was such a beautiful piece of furniture, and that was all that was said. Several years later, following her death, her attorney called and asked me when I would like to come and pick up the piece of furniture. And I still have that furniture in my home today. So I was really surprised because I wasn't expecting that, and I had no hint from her that she was going to do that. I want to talk a little bit about the most gratifying, somewhat tangential encounters I had. One was the recruitment of Dr. Bart Warner, a resident family practice physician in Memphis. Barbara and I prepared a house on the corner, it's still there, of Manny and Bell Street for a doctor's office. And I was drowning with patients, and other primary care physicians were having difficulties. We had to have some help. So I went to Memphis and met with Dr. Warner and recruited him. He and Lucy came to Murfreesboro, and it was a wonderful, wonderful experience. My association with Dr. Robert Hackman for 30 plus years was extremely gratifying, and also my association with Dr. Bob Sanders and the Rutherford County Health Department was a very gratifying experience. Pat's here tonight, and I so appreciate that relationship. The influence I had in bringing Dr. Charlie Goodman to Murfreesboro as our first dermatologist, that was a very, very gratifying experience. And I cherish that relationship even to this day. The part I played in the recruitment of multiple other physicians for Middle Tennessee Medical Center, Dr. Robert Dre as our urologist, Dr. John Pearson as nephrologist, Dr. Bill Noah, pulmonologist, Drs. Gary DeWeese and Tina Gresham, cardiologist, and Dr. Warren McPherson, neurosurgeon, Randy Rickard and Susan Andrews as family practitioners and some others, but these particularly stand out in my mind in my relationship in trying to encourage them to come to Murfreesboro to practice. Finally, the part we played in the sale of Middle Tennessee Medical Center to St. Thomas Baptist Hospital was important. We discerned that the administrator was about to sell our hospital, which was a not-for-profit hospital. He was contemplating selling the hospital to HCA, Hospital Corporation of America, which was a for-profit hospital. And we physicians, a small group of us, said, oh, we just do not want that. Our referral pattern had been primarily to St. Thomas and Baptist in Nashville, not so much to Parthenon Pavilion. I sent a patient to Parthenon Pavilion a few months before that, and the gastroenterologist to whom I had sent the patient called me later and said, you know, we can't accept this patient. Parkview won't let us keep him because he doesn't have any insurance. And that was an appalling situation. I said, we'll just send the patient back to Murfreesboro and we'll do the best we can. And he subsequently expired sometime later. But we were able to reverse that procedure, sell the hospital for $40 million to St. Thomas and Baptist, and ultimately that resulted in the evolution of the Christy Houston Foundation. The rest is history and what we have profited from that. So I like to think that maybe we had just a little bit to encourage that sale and that reversal. Now a little bit about the history of medicine, as I said, over the last half of the 20th century. There were some diseases that we sort of concluded. You might think of it in that manner. Polio, for example. I never, ever saw a case of polio in my practice. Dr. Jonas Salk had perfected the polio vaccine in 1955, and in 1961, oral polio vaccine came available by Dr. Albert Sabin's expertise. Also, we abandoned smallpox vaccination, if you recall, in the 1970s. The World Health Organization had said it's no longer a threat to society. We no longer need to keep up that, so we abandoned giving smallpox vaccination, which was a good thing. Across the state, TB became less problem. We closed the state hospitals, Middle, East, and West Tennessee, the tuberculosis hospitals. We closed the psychiatric hospital statewide, Central State, Western State, and that in some ways we redid those institutions of chronic psychiatric disease patients, and unfortunately they have just sort of floated around in our society. Alan Gooch sees them out at the Benevolent Cemetery under the bridge, and they're in jail, and it's sad what's happened, but the state felt that we needed to close these institutions. It was costing too much money, and that's what happened. We had things to happen in the radiology segment of medicine. We had been doing IVPs, barium enemas, upper GI series, and those things. And then came along in the mid-1950s, we had ultrasound to come in, and it was a very safe practice because it didn't subject you to radiation, and it told us a lot about organs within the abdomen and elsewhere. So ultrasound in the mid-1950s, the CT or CAT scan in 1972, the MRI in 1977, and the PET scan in 2000. All of these have been just instrumental in improving our patient care and treatment. We also had organ transplants. The kidney transplant came about 1954. And what a great thing that was. We were able to relieve patients who had been on long-term dialysis by giving them a kidney. Liver transplants came along about 1963. You know what necessitated the bulk of liver transplants? Tylenol. Tylenol. Teenagers overdose on Tylenol. It will flat knock the liver out. I had a patient who took an overdose of Tylenol, and I thought she was going to die or have to have a liver transplant. And fortunately, after about 3 weeks, she was able to turn it around and did not necessitate a liver transplant. But I was told by the authorities that the majority of our liver transplants were caused by abuse of Tylenol. And it's not a safe drug altogether. The other organ transplant that I mentioned is the heart. As you recall, Dr. Christian Bernard in December 1967 in South Africa did the first successful heart transplant. I had just been in practice about a year and a half, and that was really earth-shaking to think that we would have a heart transplant. Dr. DeBakey and others in the United States followed with transplants as well. Another thing that was earth-shaking was the discovery of some diseases, the cause of some diseases. Number one, peptic ulcer disease. We had been treating patients with peptic ulcers, stomach ulcers, duodenal ulcers, small intestine ulcers. We've been treating them with this aggressive surgery, what we call Bill Roth 1, Bill Roth 2, and vagotomies. We thought that ulcers were caused by acid production, so we would cut the vagus nerve, which was the nerve that caused the stomach to produce acid. We'd go in there and cut that, take half of the stomach out, half of the upper small intestine, and sew them back up with just a half of a stomach and small intestine. And it was not a good way to treat, but it was the only thing we knew to do. What happened? In Australia in 1982, a physician there discovered the H. pylori bacterium. Peptic ulcer was caused by that bacterial infection. We developed a 4-drug regimen to treat that for 2 weeks, and they were cured. We haven't done a Bill Roth 1 or Bill Roth 2 surgery since. I mean, that just wiped out the surgeons. It was amazing, but it was wonderful. AIDS. We found out AIDS was caused by a viral infection. We developed a 4-drug regimen to combat that initially, but if you believe it, those four drugs are combined now into one pill, 1 time a day. And that's the maintenance and cure for AIDS, essentially. Hepatitis A, B, C, all caused by viral infections, and we have treatments for those. Non-Hodgkin's lymphoma, we've been able to manage that in many ways, and if it's caught early and treated, patients can live many years with non-Hodgkin's lymphoma now. Childhood leukemias, acute lymphocytic leukemia in a child is cured 90% of the time, thanks to institutions like St. Jude, Vanderbilt, and others. Interestingly enough, in that case, there have been no new medications devised for acute lymphocytic leukemia since 1960. We just utilize sequencing the treatments, and those kids do quite well. Adult onset leukemias are a little bit more difficult to manage than childhood leukemias, but we do have pretty good treatments for acute lymphocytic leukemia and acute myelocytic leukemia, and that's wonderful that we can combat those. There are new approaches to treatment that I call to your attention. Breast cancer, for example. We used to do, and we still on rare occasions do, radical mastectomies, where you remove the breast as well as the muscle beneath the breast, a very aggressive, brutal kind of surgery that we try to get away from that anymore and doing what we call wedge resections, sometimes just a lumpectomy. And we have genetic risk profiling with BRCA mutations, BRCA 1 and 2 mutations, and so we've advanced greatly in that treatment. I call attention to treatment of malignant melanoma. Dr. Goodman would be better to speak on this than I, but I used to see a patient in the 1960s and 70s with a black mole, which was melanoma. That would be biopsied, and that was a death note for that patient within 3 months, in essence. I mean, it was fast moving. So, fortunately, we got more intelligent in managing that, and we decided that a wider excision would help to manage that, and the melanoma would tend to have branches and tentacles that would move out and branch out, and these would metastasize. And we now, immunotherapy is the treatment in those cases, and very few of them come to their demise as a result of the melanoma. We have the Mohs surgery, M-O-H-S, Mohs surgery, for non-melanoma skin cancers. These dermatologists, pathologists section that squamous cell carcinoma on the face or part of the body, and they'll keep shaving that until they get clear margins, and there will be no recurrence of that tumor as the result of that treatment. Of course, you're aware of all the endoscopic surgeries. Gallbladders were removed by endoscopic surgery, and that was a great invention to be able to manage gallbladders, colon cancers, stomach cancers, appendectomies we could do with endoscopy, and so forth. We have robotic surgery now, particularly for prostate and ovaries and so forth. A great advancement has been total joint replacements for patients with severe degenerative joint disease, and made them able to avoid a lifetime in a wheelchair. We've had advancements in heart disease management with stents and bypass surgery and valve replacements, so forth. Advances in the treatment of diabetes. We have the insulin pump for type 1 diabetics now, and it's a wonderful advancement. It comes to my mind a diabetic patient I had several years ago, a young white male who presented with this intense thirst, which is a symptom of diabetes, and his mother, he was getting up at night and going to the kitchen to get a drink of water, and he was waking the family up, and his mother told him, "I want you to quit doing that. You're disturbing our sleep every night." So what did he do? Raised the window, went out in the yard to the hydrant and got him a drink. And she never forgave herself for handling him that way, but that was interesting. We had the evolution of auxiliary medical trainees, as you're well aware. We had the nurse practitioner, the physician assistants, and the hospitalist. The only malpractice lawsuit I ever had in 45 years practice was when my physician assistant saw this patient and did not diagnose the patient having an evolving heart attack. The patient wound up with, unfortunately, just minor heart damage, but it cost me $100,000 in my malpractice insurance in a non-contested lawsuit. And I concern myself. I think physicians are taking a lot of chances in utilizing these auxiliary individuals in their practices, because you are liable for their management, and you better be certain that they are capable of taking care of the patient and the patient's needs. I had a great passion for elder care, and I was the medical director for 27 years at Rutherford County Nursing Home. We never had a case of decubitus, ulcers or bed sores in the nursing home that evolved within the nursing home. They always came in either from the hospital or from a home situation or a setting such as that. That was one of our best nursing homes in the county. And people supported it and continue to support it. It's a very good nursing home even to this day. And don't forget that. I was also interested in assisted living. I was a charter board member at Stones River Manor, which came about in 1977. And assisted living was a necessity that we needed to get involved with. Hospice care is wonderful, and we have a facility here in Murfreesboro now that's second to none. In conclusion, what are the challenges that remain in medicine? Of course, number one probably is cancer of all organs. Number two, and these are not necessarily in the order that one might say they need to be, Alzheimer's disease. We can't seem to come to the realization that this is a horrible disease that we don't have a good treatment for. The third thing is smoking and lung cancer. We can't seem to get a handle on that totally. The next thing is opioid epidemic, alcoholism, addiction. We have real problems in that area. And finally, the obesity epidemic and our crisis. So we have challenges that remain, and we have to acknowledge that. Medicine has been a great quest or journey for me. It truly is an art in which you use skills, knowledge, and proficiency in your medical adventure. As I was nearing retirement, the nurses at the hospital would say, "Dr. Tolbert, you are a dying breed. You are a dying breed." I was honored by my colleagues in being awarded the Owen Williams Distinguished Service Award in 2008. I had served prior to that as Chief of Staff of Middle Tennessee Medical Center on 2 occasions, and was president of the Rutherford County Stones River Medical Academy for 1 term also. I want to conclude my speech tonight by reading this note from one of my former patients that she sent me just 2 months ago. "Dear friends, I hope both of you are well and happy in your retirement. Had thoughts of what we all miss about you, Dr. Tolbert. You have helped me get through some difficult times over the years, and I just want to thank you again for being the best doctor and friend Murphstar has or will ever have. And I know you hear this a lot. It's not the same anymore. I see another physician, and she's nice, but no one can replace you. I hope both of you are well and happy. God bless both of you. Take care.
Are there any questions?
Yes, Dr. Tolbert. If I understand correctly, you've got some children that have pursued your medical career there in some form or fashion. And you might elaborate about them?
I have two sons who are physicians. Some of my colleagues commented and said, why in the name of Pete did you have two boys going to medicine? That's the worst field they could go into. I really didn't have a lot to do with it. They chose that themselves. And I have one son who was in practice with me as an internist for 5 years. And he decided he wanted to go back and subspecialize and went back to Emory and did a subspecialty in oncology, and he's in Atlanta doing that. I have one son who's a cardiologist at St. Thomas Baptist group, and I have a daughter who's a professor of history at the University of North Carolina in Greensboro, and one son who has a small nursing home business and works out in Chattanooga. So that's my family.
Right.
Thank you for asking.
Any other questions?
Okay, I hope I didn't run over.
No,
It was one, thank you.
I've always had a
Fantastic.
question that I know the answer to. Who all seen this cover from the winter 1988 publication of Dr. Tolbert with a cage beside him?
That was the old county farm poorhouse, insane asylum, and it's no longer in existence. I hate in some ways that we had to do away with it, but it was a real risk and a liability to keep it there. But that's what the picture is. At County Farm Road? At County Farm Road.
That's how we met.
Yeah.
But thank you again. I'm proud to call you friend.
Y'all finished